Welcome to this lecture on radio tracer chemistry for the radionuclides that are used in PET-CT imaging. These are the objectives for this discussion. PET radiopharmaceuticals differ from general nuclear medicine radiopharmaceuticals in a few different ways. First, they carry much higher energy. They are all positron decay, and so all of them have a really high energy in order to overcome the binding energy of the nucleus. That positron particle is very high energy, and then when it annihilates, and has that annihilation reaction, we have the 511 keV photons that are also high energy. And then it also has a shorter half-life. Almost all of our PET radionuclides will have a shorter half-life than the general nuclear medicine ones. There are a few exceptions to the rule. For example, copper 64 has a longer half-life than some of our general nuclear medicine imaging, but for the most part, especially our cyclotron-produced radionuclides tend to have a shorter half-life. Time dominates all aspects of a PET study, especially the synthesis of the radio tracer, and that goes back to the shorter half-life of the PET radionuclides. PET tracers must be synthesized and imaged within a time frame that's compatible to the half-life of the isotope. Some of them are biologic components, and they don't require any tagging or any further manipulation or production. And that's great because those also tend to be the ones that have a shorter half-life. The shorter half-lives really do give less flexibility with the injections and with imaging. PET radio tracers are injected intravenously. The procedures must be developed to yield radio tracers that are chemically and radiochemically pure, which means they must be sterile and they must be pyrogen-free. When we are creating radiopharmaceuticals with our PET radionuclides, they are produced in synthesis modules and hot cells. The radiopharmaceuticals are produced in these automated lead-shielded hot cells. Image that you see here in the top right corner is a FastLab 2 made by GE, and that's a synthesis module hot cell. They contain all the chemicals that are needed for a specific radiopharmaceutical. They also contain the tubing, the vials, any heaters that may be needed, anything like that. And it uses the specific program steps to control the liquids, the heat, and the reagents that are used. It may be as simple as combining gas into the liquid form for O15 water, or it may create a complex peptide-bound radiopharmaceutical like we see for the PSMA or the neuroendocrine tumor imaging. So these are some examples of some commercially available hot cells with synthesis modules. You see that some of them are really complex looking. Some of them are really kind of rough and not pretty looking, but they all have the reagents, the tubing, everything that's needed to produce these PET radionuclides. Now to talk a little bit about PET radiopharmaceutical QC. PET radiopharmaceutical QC is controlled by 21 CFR 212. The radionuclide impurities can originate from two sources during production: the radionuclides produced during the target irradiation and the target material impurities. The level of long-lived radionuclide impurities do not vary considerably from one batch to another. It is advisable to validate the integrity of the production method. Quantification is determined using high-resolution multi-channel analyzers, and the half-life determinations for routine identity testing of PET are performed using a dose calibrator and a linear regression analysis. This is usually not done by a PET-CT technologist. This is usually done at the pharmacy. Radiochemical impurities may originate from incomplete labeling, breakdown of the radio-labeled preparations with time as a result of instability, or through the introduction of inappropriate ingredients during the process. Radiochemical impurities can hinder clinical interpretation by decreasing the target to non-target ratio. A lot of times you'll end up with other radionuclides that are bound in there that are not what you want. This can also cause altered biodistribution, increased radiation absorbed dose to the patient. The radiochemical purity analysis can be performed by gas chromatography, high performance liquid chromatography, or thin layer chromatography. It depends on which radionuclide was produced. The high performance liquid chromatography is the fractions that are collected can be identified and quantified using a UV detector to determine how much purity there is, and that's assayed by a well counter, or the thin layer chromatography strips are analyzed using a chromatograph scanner, and that's used to demonstrate the distribution of radioactivity along an intact strip in order to determine that radiochemical purity. Because synthetic methods are utilized in the preparation of PET compounds, analysis of chemical purity is absolutely necessary to characterize and determine the quantity of potential chemical contaminants in the final product. Several methods are used, including gas chromatography, HPLC, spectrophotometry, ion exchange, and solvent extraction methods. Using the example of F18 FDG that we talked about in a previous presentation, a colorimetric test for detection of cryptofix 2.2.2 has been developed to streamline the chemical production of the product. With that test, one can interpret whether the level of cryptofix is within the acceptable regulatory limits, and the monograph for F18 4-deoxyglucose. Sterility is also important. Testing is done to provide assurance that the aseptic preparation of the radiopharmaceutical was conducted properly. The official sterility test will take 14 days to be completed. USP has given short-lived radiopharmaceuticals an allowance to release before completion of these tests. Sterility test includes inoculation of a sample of a prepared product in both fluid and soybean casein digest media. The fluid method demonstrates the growth of anaerobic and aerobic bacteria, and the soybean casein method demonstrates the growth of fungi and aerobic bacteria. Pyrogens are also important to check for. Pyrogens are agents that cause a rise in temperature or a fever. They're considered to be heat-stable byproducts of the growth of bacteria, yeast, and mold. So they're often sometimes referred to as the mean bacterial endotoxin. The manufacturers are required to perform sterility and bacterial endotoxin testing on all their products prior to release. The short-lived radiopharmaceuticals, though, prohibit the testing before the patient administration. So this is not routinely performed in nuclear pharmacies. The test The bacterial endotoxin test performed using the amebosate lysate and completed within 30 minutes. The max limit for that is 175 USP endotoxin units per max volume of injection. pH is also important to check for any radionuclide that's being injected intravenously. The individual USP monographs provide the acceptable pH range for the PET radiopharmaceuticals. You can find this acceptable range listed in a package insert. Assessment of pH can be performed using pH paper, and standard buffers should be used to initially characterize the accuracy and therefore qualify the pH paper when it's used. And again, this is not something that a technologist does. This is something that's done at the nuclear pharmacy. But it's something that technologists need to know for each radiopharmaceutical. And so that can be found in the package insert. This is an example of the tests that are performed for F18 FDG. So it looks at the appearance, the radionuclide identity, the radiochemical identity, the bacterial endotoxin test, the pH, radiochemical purity, radionuclide purity, chemical purity, residual solvents, filter membrane integrity, and the sterility of the drug. If performing any PET studies on pediatric patients, there are several different formulas that are known and recognized for pediatric dosing. Because this is largely dependent on the facility, we're not going to go into a lot of detail on pediatric dosing, but one common method that's used is Webster's formula, and there's the formula for it there. Another very common method is Clark's formula. For this one, the adult dose is multiplied by the child's weight divided by 150 pounds. And again, which method is used is going to depend on the facility and protocols and procedures for that institution. Now to talk about specific PET radiopharmaceuticals, there are several. So carbon 11, F18 fluorine, nitrogen 13, rubidium 82, gallium 68, and copper 64 are the most commonly used PET radionuclides. There are several that are in clinical trials and in development, but these are the ones that are most commonly used and that are FDA approved. Now within that you have several different radiopharmaceuticals. So radiopharmaceutical production, typically by cyclotron, you have F18, copper, or carbon 11, copper 64, nitrogen 13, oxygen 15, and then iodine 124. Iodine 124 is largely still in use in clinical trials and not necessarily something that we use. And then generator is rubidium 82 and gallium 68. I have copper and gallium in red. Copper can also be reactor produced, although it is mostly produced in a cyclotron. And then gallium can also be cyclotron produced, although we most commonly see it produced by a generator. And these are the radiopharmaceuticals. I have little icons by them to help you understand their use. FDG has no icons by it because it has a wide variety of uses in neurology, oncology, cardiology, and infection inflammation imaging. It's used for a lot of different things. The F18 fluorbetabin all the way through fluorodopa. Those are all used for neurology imaging in different ways. F18 sodium fluoride is used for bone imaging. Fluciclovine, Clarify, those are both used for prostate imaging. That's why they have a little man beside them. Fluorestradiol is also commonly known as Cerianna. That's used for breast cancer imaging. Carbon 11 acetate has a lot of different uses. It's used in prostate imaging, cardiac, renal studies, and studies of the brain. Carbon 11 choline is used for prostate imaging. Now, because of the half-life of carbon 11, those have not widely been accepted, and it's very difficult to get them commercially available because of the short half-life. copper 64 dotatate through gallium 68 dotatalk. Those are all neuroendocrine tumor imaging. The zebra icon is there because that's the mascot of neuroendocrine imaging. Gallium 68 gozdotide, that's commonly known as Illuccix or Locomets, and that one is has a little man beside it because it's prostate cancer. N13 ammonia and rubidium 82 chloride are cardiac imaging agents. So these are the cyclotron-produced metal PET radionuclides, and with their half-life, their decay modes, of course, they're all going to be primarily positron. I do want to point out that you see some of them are also electron capture. That's what that little EC stands for. If you recall from the previous lecture, positron decay and electron capture are similar, and typically if it's a low energy atom, it will undergo electron capture. Higher energy will undergo positron, but there are a number of radiopharmaceuticals who decay by both means, and it's typically normal to see PET radionuclides that also give off an electron capture photon. So their max energy is listed there in MeV. It's a lot higher energy than the KeV that we use for general nuclear medicine imaging. The chemical reaction that occurs is posted there, and then of course the natural abundance of the target isotope. These are generator produced PET radio or PET isotopes, and the only ones on here that we really use on a regular basis are in the middle, the rubidium 82 and gallium 68. But again, this shows you the daughter half-life, the decay mode. Almost all of these are positron and electron capture. They all are. The maximum energy, again, that's an MeV. These are high energy reactions. The parent half-life, and then the parent's decay mode. The first radionuclide that we'll talk about is carbon-11. Carbon-11 has a half-life of 20.4 minutes. It is cyclotron produced using nitrogen-14, adding a proton, and then the resultant is carbon-11 plus helium. This decays to boron-11, and it is widely used in research, easily tags to compounds and lignins. Carbon-11 choline and carbon-11 acetate are the two most commonly used. And this is widely used in research, but is also largely restricted to research facilities that have a cyclotron on site because of the 20-minute half-life. Now, carbon-11 choline, the chemical form is choline. Choline is a central nutrient formerly classified as a B vitamin. It's similar to an amino acid in structure and function. The cell structure, fat transport, cell messaging, DNA synthesis, and nervous system. Choline plays a role in all of that. Heartbeat, memory, muscle movement, and so it has a wide variety of uses for cellular function. It is indicated for patients with suspected prostate cancer recurrence and non-informative bone scintigraphy, CT, or MRI, and that's because it is involved in the progression of prostate cancer or the metastases of prostate cancer, and so it's used for suspected prostate cancer occurrence. Typical dose when it's being used for prostate cancer, 10 to 20 millicuries, and because it's a prostate cancer agent, there really isn't a pediatric dose that's indicated. It is a water-soluble nutrient, and it's transported into cells as a precursor for biosynthesis of phospholipids, which are cell membrane elements. The choline represents fatty acid metabolism of cell membrane production, and this is more metabolically active in prostate cancer cells especially when metastasizing. And so that's why it's become a good agent to use for that. This is an example of images taken with carbon-11 choline. The activity that you see up here in the axilla area and the upper arm of the patient are from the injection. And that's not contamination, that's just residual activity that's kind of hanging up in the venous system. The next one is carbon-11 acetate. This is a monocarboxylic acid ion. This is used for energy expenditure, lipid metabolism, and innate immune responses within the cells. It is quickly metabolized into acetyl-CoA in human cells. In this form, it can either enter into a tricarboxylic acid cycle, producing energy, as in the case with myocardium, or it can participate in cell membrane lipid synthesis, such as what happens in tumor cells. And that's one of the reasons that acetate is used for a wide variety of things. It's used for myocardial blood flow reserve, renal cell carcinoma, hepatocellular carcinoma, multiple myeloma, gliomas, and some rare tumors. And this is an example of the images taken using carbon-11 acetate. The activity that you see here is the pancreas, and then you have the liver there. You have a lot of activity in the face. It's just kind of normal muscle uptake. Now we'll move on to the F18 radionuclides. These are things that are tagged to F18 fluorine in order to make a radiopharmaceutical. As you can see, there is a wide variety of F18 agents that are used for PET. And part of that is because F18 has a short positron effective range, which means that positron is going to travel shorter before it annihilates. That increases the spatial resolution when we're working with F18 agents. It also, because of the chemical nature of F18 fluorine, it has really good tagging capabilities with a wide variety of compounds. As you can see from the list, some things are really simple, like the sodium fluoride. Some things are really complex, like the Ceriana or the Plurify. And so it does make it a very useful agent for imaging. So F18 is cyclotron produced. It comes from oxygen 18, has a half-life of 109.7, 109.8 minutes. And the most common radiopharmaceutical that's used is the F18 fluorodeoxyglucose, which is used for infection and inflammation imaging, oncology, cardiology, and neurology. The mode of localization, FDG is an analog of glucose and is transported across the cell membrane by the same mechanism as glucose. This comes directly from the package insert for F18. The mechanism of uptake or the method of localization is metabolic pathway because it is taken into the cells the same way that sugar is. However, once it gets into the cell, it is not synthesized in the same way, so it will not increase the patient's blood sugar at all. Because it doesn't really get used once it's in the cell. It's got that slight little difference to it where it's a little bit different from regular sugar, and so it doesn't get synthesized by the cell. So taken up but not used by the cell, that allows us to see the metabolic activity of the cells because we see how much FDG the cell took up, but it gets trapped in the cell and stays there. That's a great quality for imaging. But that also is the reason that it doesn't increase the patient's blood sugar, even though we're injecting them with a radioactive sugar or radioactive glucose. The typical dose for F18 is 5 to 10 millicuries, even though it has a wide variety of uses. It's kind of the same dose for everything. And it expires typically 12 hours after the end of synthesis. And the critical organ is the bladder wall. Because it is excreted through the urine, the bladder will end up getting the largest amount of radioactive dose. Areas of normal uptake for FDG. The brain is always extremely hot because the brain metabolizes sugar. We'll also see activity in the liver, kidneys, and bladder. The kidneys and bladder will often be very hot on images because it is excreted through the urine. The myocardial uptake will vary greatly depending on the fasting state of the patient. If they're non-fasting, then you will have a lot more increased uptake of FDG in the heart. Uptake can also be seen in the brown fat, which shows up in the back, shoulders, and neck. And in oncology, you will see focal areas of increased uptake outside the normal biodistribution in areas that are of concern for malignancy, infection, or inflammation. It's very important when you're using FDG to get a very thorough patient history because if you're looking for oncological reasons, for example, and they have infection or inflammation somewhere locally, then that may be mistaken for malignancy if it's not appropriately documented. So very important to get a good patient history with FDG. Now, FDG is used for glucose utilization and metabolism in the brain, the heart, and neoplastic diseases. Like I said, the typical adult dose is about 5 to 10 millicuries. Sometimes you'll see a little bit more. Sometimes that dose also depends on the scanner and how sensitive and efficient that PET scanner is. You don't want to give too high of a dose and end up oversaturating um, the PET scanner because that will lead to dead time and things like that in the images. And then the typical pediatric dose, typically the only time we give FDG to pediatric patients is for neurology or oncology uses, but the typical dose for pediatrics for neurology is 2.6 millicuries. Otherwise, all other locations or all other reasoning to do the study, then you would follow the pediatric dosing at your facility. So this is an example of FDG with normal uptake. So as you recall, I said that the myocardial uptake is greatly dependent on the patient's fasting state. So this appears more to be non-fasting. These are the helices of the kidneys where the urine is collecting. And then you see even some activity in the ureters and the bladder. And then up here you see the base of the brain is showing up really hot because it takes up a lot of the sugar. Now for the F18 amyloid plaque agents, the commercially available ones are Neuraceq or florbetaben, Amivid, also called florbetapir, and then flupmetamol under the trade name of Vizamyl. These are all beta amyloid plaque agents, and they're used for the estimation of beta amyloid plaque density in patients with cognitive impairment, such as dementia or Alzheimer's disease. Method of localization is receptor binding because it binds to the beta amyloid plaque in the brain, and it localizes more in the white matter. The critical organ is the gallbladder and the large intestine. And this is an example of the amyloid plaque agents. Now, typically, if it is a negative scan, you will not see a lot of activity in the brain because it's going to the amyloid plaque, and there's more amyloid plaque in cases of dementia and Alzheimer's. So a positive scan would be marked by increased uptake in the brain. Fluortaucipir, also known as Talvid, This is the tau imaging agent that is used for the detection of Alzheimer's disease or evaluation of it, I should say. And tau is a group of 6 highly soluble protein isoforms. They maintain the stability of the microtubules in the axons. Typical functions of tau include cellular signaling, neuronal development, neuroprotection, and apoptosis within the cell. And so the use of tau-vid imaging is for the estimation of density and distribution of the aggregated tau neurofibril tangles in patients with cognitive impairment. What we're really looking for is to see if they have Alzheimer's or if it's progressing, kind of stage it, look at the efficacy of treatments or drugs that are used. The typical adult dose for this is 10 millicuries. Method of localization is protein binding. The critical organ is the intestines. And the normal biodistribution, really there should be no increased neocortical activity or show increased neocortical activity isolated to the mesial temporal, arteriolateral temporal, or frontal regions. There really should not be a large presence of tau proteins in the brain. The presence of a lot or a large number of tau proteins is usually indicative of Alzheimer's disease. This is an example of F18 fluortaucipir. The top row there is a normal scan. Notice there's not a lot of tau proteins present in the brain, no areas of large accumulation of tau proteins. And then the bottom scan is abnormal. And in that one, you do see that it's marked by the green scale that you see, where there is a lot more uptake and localization of tau protein within the brain. Now, the last neurologic agent that we're going to talk about is F18 fluordopa. This is used to visualize dopaminergic nerve terminals in the striatum for evaluation of adult patients with suspected Parkinsonian syndromes. This is very similar to DAT scan if you're familiar with general nuclear medicine imaging, but this is the PET patient. You cannot diagnose somebody with Parkinson's disease based on fluordopa only. This is used as an adjunctive to other tests like CT and MRI, as well as cognitive and neurologic function tests. This is the package insert for fluordopa. It is localizes by receptor binding. Indications for it are PET imaging to visualize the dopaminergic nerve terminals in the striatum for the evaluation of adult patients with suspected Parkinsonian syndromes. And critical organ for this one is the urinary bladder and areas of normal uptake. Really, you would see the putnam in the caudate of the striatum. Optimum presentation of the reconstructed images for visual interpretation is the transaxial slices. And you should see all of the putnam in the caudate. It looks kind of like that semicolon look to it, and it should be symmetric and look the same on both sides of the brain. So this is what I mean by that kind of comma, I guess I should say, and backwards comma. This is normal uptake within the brain. As you start losing the shape of that, and sometimes it'll be lost on one side but not the other, but this kind of progresses from stage 1 to severe stage 3. The next F18 agent is sodium fluoride. This is used in bone imaging in areas of altered osteogenesis. This is an alternative to MDP and HDP imaging of bone scans for general nuclear medicine. And the mode of localization is very similar. Those ones are a phosphate, and this one is a fluoride. So it's slightly different mechanism. but it still will deposit in the bones via chemoabsorption and become a part of the bony matrix. The typical adult dose is 8 to 12 millicuries, and there are a couple different methods for calculating the pediatric dose. Again, that is largely dependent on the facility. Sodium fluoride normally accumulates in the skeleton in an even fashion, with greater disposition in the axial skeleton. And this is very similar to the MDP, HDP bone scans that you'd see in general nuclear medicine. It's a very similar uptake. It diffuses through the capillaries into the bone's extracellular fluid space, where it becomes bound to chemoabsorption at the surface of the bone crystals. And the critical organ for sodium fluoride is the urinary bladder wall. It is excreted through the urine very similarly. It also expires within 12 hours of being made, and typical areas of uptake are the bones, kidneys, ureters, and bladder. Kidneys, ureters, and bladder show up because of that urinary excretion, so really it localizes to the bones. Now, the sensitivity and specificity is a little bit higher with sodium fluoride, but again, with bone scanning, it is not very specific to one disease or another, but it is very specific to osteogenic changes in the bone. So if there's a problem with the bones, it will go there, but it doesn't necessarily distinguish between sports injury, old injury, new injury, things like that. And this is an example of sodium fluoride bone scan. You do see the axial skeleton really well. You get a lot of detail in the vertebrae and the ribs, as well as the pelvic girdle. And it does go to the perpendicular skeleton a little bit better than MDP, HDP. This mostly has to do with the increased spatial resolution that you see with PET imaging. And in this patient, you even see a little bit of increased uptake here, but for the most part, this is a normal bone scan. Now we'll talk about some of the prostate imaging agents that are fluorine-based. The first one is F18 fluciclovine. This is commercially available as Axumin. And this is used to identify and localize suspected prostate cancer recurrence in patients with elevated PSA. The method of localization is receptor binding. Typical adult dose is 10 millicuries, and because it's prostate cancer imaging agent, there really isn't a pediatric dose that's indicated. This is the package insert for fluciclovine. The method of localization for this one is receptor binding. It is indicated in men with suspected prostate cancer recurrence when they have elevated PSA levels in their blood following prior treatment for prostate cancer. And fluciclovine is a synthetic amino acid. This is very different from the PSMA agents. This is an amino acid that is present in patients or upregulated in patients who have prostate cancer cells. So it will go to areas where there is prostate cancer recurrence. Normal biodistribution for this one is liver, pancreas, lung, red bone marrow, myocardium, and the skeletal muscle. Notice that skeletal muscle, not the skeleton. And it is based on the amino acid presence within prostate cancer recurrence. This is an example of fluciclovine. It is very common to see the pancreas, although we don't see it on these images. And these are not the same patient, of course, these are different patients. So the next agent is F18 plifliflostat, and this is commercially known as Plarify. So I want to point something out with the difference between the PSMA agents and the fluciclovine agents. So the fluciclovine is a synthetic amino acid. So it's going to go into prostate cancer cells as they're reoccurring and they're taking up more of the amino acids. But the PSMA agents are only going to go to prostate cancer metastases that have that prostate specific membrane antigen overexpressed on the surface of their cells. As prostate cancer progresses, it becomes more and more heterogeneity within the tumor, which means it stops taking up the prostate specific membrane antigen. It stops being a metastatic prostate cancer cell and just starts being a cancer cell. And so, as the prostate cancer progresses and those cancerous cells become more and more cancerous cells, they lose some of that differentiation between like prostate cancer cells and normal cells. And so they just become cancer cells. At that point, they stop overexpressing PSMA, but they may still be taking up sugar or amino acids. And so that's kind of the difference here. But as that prostate cancer starts to metabolize, typically it will take up the PSMA. Typically it will have PSMA receptors on the surface of the cell. And that's where PSMA really has an important role in prostate cancer patients. So the Clarify is for suspected metastases based on elevated PSA levels, but it's also to evaluate if those candidates may be eligible for PSMA therapies using Lutathera. And so that Clarify plays a really big role in that. It is possible that they have prostate cancer metastases, but it's no longer got PSMA um, on receptors on the surface of the cell. In that case, they would not be candidates for the Lutathera therapy. So that's an important distinction with the PSMA agents. But for Clarify, the method of localization is receptor binding, and it goes to the PSMA receptors on the surface of cells. This is the package insert for Clarify. Mechanism of uptake is receptor binding, and it will bind to cells that express PSMA, including malignant prostate cancer cells. Now, PSMA is a misnomer because that is something that is in our bodies anyway, male and female. It has to do with folic acid metabolism in the cell and quite a few other normal cellular functions. But it is overexpressed in prostate cancer cells. So that's what they're looking for with PSMA studies. And critical organ is kidneys, liver, and spleen. And it will typically expire within about 10 hours. These are some examples of patients who had Clarify studies. A is a normal study progressing all the way down to G, which is abnormal. In A, there is one suspicious spot there near the prostate, but of course you can see a huge difference between A and G. So that is various levels of metastases with various levels of PSMA uptake within the cells. And the last F18 agent that's FDA approved is F18 fluorestradiol. This is used for the detection of estrogen receptor positive lesions in patients with recurrent or metastatic prostate cancer. The mode of localization for this one is receptor binding, and it's going to bind to estrogen receptors on the surface of breast cancer cells. Typical dose is fairly small, it's 3 to 6 millicuries, and because this is a breast cancer agent, there is no pediatric dose that's indicated. This is the package insert for fluorestradiol. It is receptor-based tracer, so its method of localization is going to be receptor binding. And it's going to bind to the ER cells on the surface of breast cancer cells. It expires within about 12 hours. Critical organ is liver, gallbladder, and the uterus. F18 fluorestradiol distributes primarily through the hepatobiliary system. It will go to small and large intestines, the heart wall, the blood, kidneys, uterus, and bladder. And it is very important to look at the SUV and other quantitative analysis when doing fluorestradiol. I do want to point out that there are other cancers, such as ovarian cancer, that will have overexpression of ER receptors on the surface. And so it is important to take a good patient history because cancer in those areas or those types of cancers will show up as well. So this is looking at FES PET versus FDG PET in the same patient. So there are a lot of areas where that breast cancer metastases is taking up that overexpression of the ER receptors. It is pretty typical in patients with breast cancer to receive both the FDG PET and the FES. It's not like it's one or the other. It's something that should be used together and compared. It is also a measure of tumor progression or cancer advancement because as the tumor progresses, as that cancer becomes more and more malignant and advances, it will lose some of its ER receptors and the cancer will become, less and less homogeneous to breast cancer cells and more heterogeneity within the cancer. So other PET radiopharmaceuticals, copper-64 dotatate, gallium-68 dotatate, and gallium-68 dotatate are all neuroendocrine tumors. The gallium-68 gosatide is another PSMA agent, and then we have the cardiac agents. So copper-64 is typically cyclotron produced, but it can also be produced in a reactor. It comes from 64 nickel, bombarding that with a proton to cause it to have positron decay. In the top right-hand corner here of the slide, you see the decay scheme for copper. It comes from nickel and then it decays down to zinc and it has that beta positive release to it. It also has electron capture. So it is the only FDA approved agent using copper is copper-64 dotatate, although copper-64 is used in a lot of clinical research and new drug developments. It is linked to a variety of bioactive molecules that can be used in theranostic agents and malignancies such as prostate, glioblastoma, melanoma, breast cancers, and also diagnosis of human copper-associated diseases such as arteriosclerosis and Alzheimer's. This is the package insert for copper-64 dotatate, more commercially available as Detect Net. The half-life of copper is 12.7 hours. This is very beneficial in distribution to patients or to facilities that are not as close to a cyclotron because it makes it a little bit easier to ship it because of that longer half-life. And then the method of localization is receptor binding. It binds with affinity to the somatostatin receptors that are overexpressed on neuroendocrine tumor cells. Administration of this one is typically about 4 millicuries, and it should be discarded about 2 hours after the calibration time. Critical organ is the liver, kidneys, adrenal glands, and the spleen. And it's going to bind to somatostatin receptors everywhere, and they just happen to be overexpressed on the surface of neuroendocrine cancers. So this is comparing copper 64 dotatate to gallium 68 dotatate in the same patients. You have patient 1 there. You see that in patient 1, the imaging looks a lot different with copper than with the gallium, and the gallium appears to have better image quality. When you look at, as you progress through those patients, if you look at patient 3 also, you'll notice that spatial resolution is a little bit better with the gallium. You can see a little bit more of the tumors, or you have a better kind of detail within the image. So now we talk about gallium. Gallium is generator produced. Although it does have the ability to be produced in a cyclotron, typically we see it produced in a generator. It comes from germanium 68. The half-life is 68 minutes. And in the top right-hand corner, you see the decay scheme. It goes from germanium, which has a half-life of 270.9 days. It decays by positron, and so it decays down into the left because it's becoming the element to the left of it on the periodic table. And then gallium 68 is going to decay by beta positive and electron capture, and it decays down to stable zinc. Gallium 68 is used for imaging neuroendocrine tumors and PSMA for prostate cancer. So the first one we'll talk about is gallium 68 dotatate and DOTATOC. There are only slight differences between dotatate and DOTATOC. They are both somatostatin analogs, and they're used for localization of somatostatin receptor positive neuroendocrine tumors. The method of localization is receptor binding. And this is a package insert that gives you a little bit information, particularly to NetSpot, which is the gallium 68 dotatate. The critical organ is the spleen, and the area of uptake is that it distributes to all somatostatin 2 expressing organs, and that is something that's important to note there, is that it has the highest affinity for subtype 2 of the somatostatin receptors. So it may go to all of them, but it overexpresses and has the highest affinity for subtype 2. And these are some examples of the gallium 68 dotatate studies. The next one we'll talk about is gallium 68 gosotide, which is more commonly referred to as Illuccix or Locomets. With this one, it has a half-life of 67.7 minutes because it is gallium 68. And the method of localization is receptor binding as well. It's going to bind to the PSMA receptors and to cells that overexpress PSMA, including malignant prostate cancer cells. Now, it's not necessarily specific because there are other types of diseases or tumors that will overexpress PSMA as well. Now, the indications for this one are patients with suspected metastases who are candidates for the lutetium-177 therapy, with suspected recurrence based on elevated PSMA levels, or for selection of patients with metastatic prostate cancer for whom will be undergoing the lutetium-177 therapy. So it's also to stage kind of image the efficacy of the Lutathera therapy. Contraindications for all these PSMA agents are androgen deprivation therapy, which is kind of common in some patients with prostate cancer. The critical organ for the gallium 68 PSMA agents is the kidneys, urinary bladder, and the spleen, with the greatest uptake showing up in the liver. It is also, there's no uptake in the cerebral cortex or the heart, and lung uptake is relatively low with the gallium PSMA agents. So this is an example of the gallium-68 PSMA. Now we talk about the cardiac agents. Nitrogen-13 is the first one. Nitrogen-13 is cyclotron produced. It is produced from pure water with trace ethanol. And you see the chemical equation there for how it's made. It's hydrogen plus stable water. So you just really are bombarding that stable water with the proton, and that produces nitrogen plus helium. The half-life for this one is 9.97 minutes, so it is fairly limited to areas where there's a cyclotron nearby. There is one company that makes a small scale. It's still very large, but a smaller scale cyclotron to produce nitrogen ammonia on site for the use of cardiac PET. So uses for nitrogen-13 ammonia are myocardial perfusion imaging, including the measurement of myocardial blood flow and myocardial perfusion. There's a decay scheme up here. Now this decay scheme does have a mistake in it because it should go down and to the left because it is a positron decay, but it is showing you that this one is 100% positron. There's no electron capture with it, and it decays to carbon. Nitrogen ammonia, like I said, is used for myocardial perfusion imaging, and the method of localization, it does have a high extraction fraction by the myocardial cells, and then it becomes trapped in the myocardium. The method of localization is actually passive diffusion because it passively diffuses into the myocardium across the capillary beds based on the perfusion. And then it gets metabolically trapped by the glutamine reaction within the myocardial cells. Typical dose is 10 to 20 millicuries at rest and stress, and there is no pediatric dose for that that's indicated. This is an example of nitrogen-13 ammonia study. It is normal that the heart walls will appear thinner on cardiac PET than they do on regular SPECT imaging of the heart for myocardial perfusion imaging, and that is in part due to the increased spatial resolution of PET imaging. Lastly, we'll talk about rubidium-82. Rubidium-82 is generator produced from a strontium-82 generator. It comes from the generator as rubidium chloride as the saline washes over it. There are two impurities that need to be checked carefully, the strontium-85 and strontium-82. Quality control is done at least daily to make sure that there's not too much strontium coming through the generator. The cool thing about rubidium is that that generator will be housed directly near the camera, and the infusion goes straight into the patient. Half-life is 75 seconds, so by the time you get the patient off the table, almost all that radiation has decayed from them. And this is used for myocardial perfusion studies, and it does give the ability to measure the myocardial blood flow reserve. And the method of localization for this one is active transport. Rubidium is an analog of potassium, and so it is extracted by the myocardium tissue via the sodium-potassium pump, and so that's how it localizes within the heart. And this is an example of a rubidium study. Again, the heart wall looks a little bit thinner on these images, and that is partially because PET has increased spatial resolution. And that's it. That's all the just about all the PET radionuclides that are FDA approved at the time that this video was recorded. There is a ton of research in PET, in lots of new radiopharmaceuticals in the pipeline. So keep a lookout for those as they get approved. I will point out that it is very important to look up package inserts of new radiopharmaceuticals so that you can understand how they go, what the normal biodistribution is, the typical dose. That's the information that the company used to get the drug FDA approved. That's where all the research is based. So that's going to be your best information for how to store the drug, what it should look like when it's normal. It should be typically they should be colorless, not cloudy or particulate within the dose, knowing when they expire, half-life of the drug, normal biodistribution, that type of thing. So that's it. I hope you enjoyed this video. Thank you.